Thank you to you all for being here today. Today's talk is about hearing and brain health. A bit about myself. My name is Jeffrey, and we're New Audio. We've got a clinic here in Hawthorne East and some clinics up north in Sydney and Queensland too. And I was initially drawn to audiology with a desire to help people like my father, who's got a considerable hearing loss, one that's much worse than the average person of his age. And I'll tell you a little bit more about his story later on in tonight's seminar. But his hearing loss had profound impacts on his ability to function and broadly to enjoy his life. So I feel very grateful to be in this unique profession where I've got an ability to make a profound impact on a person's quality of life. And I'd like to introduce Andrew Campbell. Andrew is a master's qualified audiologist and is certified in the neurological sciences. Andrew is a leader in hearing healthcare. He is a best-selling author. You've all got a copy of his book. And he is a speaker, teacher, manager, innovator, and philanthropist. Andrew was one of the founding members of one of the largest hearing healthcare groups in Australia, the founder of New Audio, Hearing and Brain Health, and of the Gain Hearing Network, which is an organization dedicated to supporting independent audiology clinics in Australia. Andrew has been recognized for his work around the world in Australia, New Zealand, Hong Kong, Malaysia, Taiwan, Singapore, and the US. So we're really pleased to speak to you today about hearing and brain health. People in our physical audience, please just turn off your phones or put your phones on silent. We will have some time later on at the end of the session to answer your questions. And hello to everyone joining us online on Zoom. We'll be available if you've got any questions. Feel free to type it into the chat and we'll attend to your questions as well. And well, thank you all for your attention. And first, we'll throw over to Andrew. Thanks, Andrew.
Thank you, Jeffrey. And thank you all for taking time out of your busy schedules to come and join us this evening. I'm just wondering, is anyone here travel any more than, say, about an hour to come to this session? Yeah? Oh, wow. Quite a few of you. I might put a couple of you on the spot. Lady at the front there. You came in, it took you a bit over an hour to get here? Yeah. Now, I'm curious, what is it that made you put on your nice jacket and travel all the way here over an hour to come to this session? Is there something specific that you really wanted to learn about this evening?
I work as a speech pathologist.
Yeah. I
have a hearing loss and I want to hear what you have to say.
Excellent. So she's for people online, she's a speech pathologist. She has a hearing loss, so she's particularly interested in hearing what we have to say. Speech pathologists generally have at least a bit of a background in audiology, don't they? So yeah, fantastic. Anyone else that travelled some distance that just came all the way here to learn something specific, like to share it all? Yeah, I do.
No, what is new area?
Okay. Excellent. So in terms of particularly the research on hearing and brain health, that's what we're going to be focusing on this evening. Actually, quite a lot of new research that's coming out even this year. So I'll be incorporating that particularly toward the end of this session and parts throughout. So all good. Now, for the people online, you will be able to access captions if you go into your Zoom and just press show captions, and that will come up as subtitles. So hopefully it makes it easier for you to follow. But in this I guess for the past 22 years in doing this kind of work, there has not been a week that's gone by where I've not come across the heartbreaking case of someone that's just simply left treating their hearing loss too late. So we know that most people here in Australia with a treatable hearing problem, they never set foot in an audiologist's office. We also know that of those people that do go and take action and do go and address their hearing problem, on average, there's around a 10-year delay from the point where people could benefit from treatment to the point where they actually go and take action. And what the science is telling us is that that's absolutely 10 years too late. We're going to be talking about a reasonable amount of research this evening. You've all got a complimentary copy of my book, where in the back there's all the scientific references that really back up what we're presenting here. What I've tried to do is distill the most important research in this area into I guess hopefully a relatable presentation. So ideally you'll leave here with at least a bit of a grasp of just how does our hearing health relate to our brain health. So we know that there's a lot of really good quality research that's been done in this area. However, it's relatively I can't say that we're at a point where it's common knowledge. There was a recent survey done of the Australian public just to try to get a gauge of just how aware Australians are about the links between their hearing health and their brain health. And what they found was that 84% of Australians had really no idea that there was any link between their hearing health and their brain health. So hopefully you'll leave here this evening with just at least a bit of a grasp as to what's going on. So we've known since the 1980s was the first, I guess, published research that I guess brought up the links that I guess correlations between hearing health and cognitive health. We can find it in the literature, but I wouldn't say that it really that it was particularly well accessed research. What really put the topic of links between hearing health and cognitive decline on the map was a major study that was done in 2011. And it was really for the first time that hearing was involved in a major multi-million-dollar study of the aging process. So there were, in this study done at Johns Hopkins University in the United States, there were 600 people in this study, all aged around the age of 60. And it is what we call a longitudinal study, meaning it was done over a long period of time, in this case over 12 years. And basically these people, actually to be part of the research, the participants couldn't have had a history of having dementia. So they were coming into this research dementia-free. And they came in every year to the university for 2 to 3 days of intensive testing. They were looking at all sorts of things known to be associated with aging: coronary heart disease, diabetes, cancer risk, arthritis, male-pattern baldness. Hearing was just a very small part of what they were looking at in this research. At the end of that 12 years, so these people are aged around the age of 72, huge amounts of data all compiled and put together. The most stunning and outstanding statistics that came out of that research were the clear links between hearing loss and dementia risk. What they found was that those people that had a mild hearing loss, so a mild hearing loss, it's about a 25% hearing loss. When I graduated from university 22 years ago, we didn't really care so much about a mild hearing loss, but given what we now know, we are most certainly concerned about it. So those people that had a mild hearing loss, they were twice as likely to have developed dementia over that 12-year period compared to their peers that had normal hearing. Those with a moderate hearing loss, so we've got a practice nearby at Hawthorne East. Most of our patients there have a moderate hearing loss. which is about a 25 to 40% hearing loss. Those people with a moderate hearing loss in the study, they're actually 3 times more likely to have developed dementia over that 12-year period compared to their peers that had normal hearing. And remember, these people were coming into this research without signs of having dementia at the outset. Those with a severe hearing loss, so those same kind of people that I mentioned at the beginning that really would have put off treating their hearing loss really too late for us audiologists to get a really great outcome in the clinic. A severe hearing loss is about a 50% or more hearing loss. Those people were 5 times more likely to have developed dementia over that 12-year period compared to their peers that had normal hearing. So these findings, they created quite a stir in the medical community, got a bunch of press coverage over in the United States, front cover of the New York Times. Not a whole lot of press attention here in Australia, but I'd have to say that slowly but surely the links between our hearing health and our brain health are becoming, I guess, gradually more well understood within at least in the medical community. I had the pleasure of meeting Professor Frank Lin, the head researcher of that study, initially a bit over 4 years ago. He was over in Sydney doing some intensive training on this topic. And also on that trip, he was over in Canberra trying to bring hearing more into the forefront when medical practitioners are considering diagnosis of mild cognitive impairment, cognitive decline, dementia, Alzheimer's disease, and so on. Because quite often people are given these diagnoses, and the contribution of hearing is frequently not taken into account or even considered as a potentially contributing factor. His team have really identified 3 core areas. If we're thinking about, well, just how can our hearing health relate to our brain health? Well, there's really 3 main mechanisms at play here. One is it relates to the whole set of factors relating to social isolation, particularly the significantly increased risk of chronic social isolation that we've known for decades can be associated with increasing levels of hearing loss. And it tends to start with, for a lot of people, it tends to start with the most common complaint that we hear in the clinic all day, every day, and that is difficulty hearing in background noise and group situations. So I know most of my patients, they're able to hear me quite okay one-on-one in a quiet situation, but as soon as they get out into, say, a restaurant, cocktail party, an environment where there's quite a lot of background noise, that's where the difficulties start. And it can get to the point where it can become potentially embarrassing if you're mishearing, you're laughing at something that wasn't a joke, or missing the punchline of what was a joke. Potentially embarrassing. Also, people tend to feel like they're increasingly on the periphery of the conversation, so they're not directly involved and in the discussion. They're sitting on the periphery, kind of feeling somewhat left out. So there becomes a point in time where those social interactions in those quite challenging environments just start to become less enjoyable. And frequently people start to disengage from them, either subconsciously or consciously, will start to avoid some of those situations that they would otherwise have been wanted to be part of. And that's where we start to really get concerned about it. I should just mention that some people confuse when we are talking about social isolation. Some people confuse that about, parties and pubs and things like that. It can actually be quite isolating even on the domestic front, not just for the person with a hearing loss, but really anyone that's interested in having a rich, nuanced dialogue with that person. We'll talk a bit about those topics a little bit later on. The second set of factors relate to the cognitive load that having a hearing loss puts onto our brain. So for the most common forms of hearing loss, it's not like people are hearing no words. Well over 90% of the time, the hearing is in better shape in the low pitches relative to the high pitches. And our primary focus as audiologists is on preserving speech. So when we're hearing the low pitch sounds quite okay, but not all the higher pitch sounds, typically we're hearing all of the A, E, I, O, U vowels, but not always the consonant sounds, which are typically the beginnings and ends of words that give the words the clarity and meaning. So vowels give the perceived volume and loudness of speech. We know someone's talking. However, if we're not getting all the consonants, then there's a good chance that we won't be getting all of the clarity of meaning, at least through what we hear. So if we're not getting all of the consonants, in order to communicate, it's going to help for us to be able to use visual cues. So body language, facial expressions, movement on lips, they all give us clues as to what that person might be talking about. Sometimes that's not enough, and we need to think of the context of the conversation, and hopefully we've got enough there to be able to understand, follow what's being said. The thing is, it takes, it's quite a lot of load on our cognitive abilities to compensate for not just hearing the words in full. So following conversation, particularly in a background noise or group setting, is one of the most cognitively demanding things that we do. It's just so much more straightforward to hear words in full when we're kind of filling in the gaps based on what we can see and adding in some context, adding that to what we can hear. It puts quite a lot of load onto our limited cognitive resources. It can start to take away from other faculties such as formation of long-term memories, balance and steadiness. We'll talk about those things a little bit later. The third set of factors relates to what the medical terminology is cerebral atrophy, which is, I guess, terminology for shrinkage of the brain. We can see up to 40% reduction in parts of the brain associated with speech, hearing, language, and memory when we've got a hearing loss that we've done nothing about. We can actually see some disorganization effects happening, which I could show you pretty clearly a little bit later. But when we're thinking about, in terms of the brain volume, these parts of the brain that help us particularly process speech, it's very much like I've got to use it or lose it. The most common forms of hearing loss are presenting a barrier or a hurdle for appropriate stimulation to get through to these critical centers in the brain. When we look at the brains of people that have a hearing loss versus those that have normal hearing, the main impacts are in regions of the brain called the right cluster, which is just kind of adjacent to our ears. What this study showed was just looking at differences in brain volume in people that had normal hearing versus those with a hearing loss. And so with these bars, the further up we go, the more brain volume we have. In blue, people that have normal hearing. So as we go up, you can see people with normal hearing relative to those that have a hearing loss. There's quite a difference there in the volume of that right cluster of the brain. We can actually see full brain impacts. So this next bar here looks at grey matter volume across the whole brain, and those that have normal hearing higher there than those that have a hearing loss there in red. So we can see up to a 10% reduction in whole brain volume in cases of normal hearing versus those in cases of hearing loss relative to those that have normal hearing. If we look at an individual, so this guy is a 68-year-old man who's got severe hearing loss in one ear and normal hearing in the other. So you can see just above this red arrow here, this is the impacted side. There's a bit less volume there. You can see it's kind of a bit of a lighter colour. So you might be thinking, well, gee, thanks, Andrew. I've put on my Sunday best. I've travelled in a number of cases over an hour to come to your seminar. only to have you here just talking all about doom and gloom. Well, the good news is that what the science is also telling us is that when we can apply the correct treatment to hearing loss, we can actually see a reversal of a number of these downstream trends. So this particular study that I've got up on the screen here, what it was looking at is what's happening in the brain in people that have a moderate hearing loss in this study. So between a 25 to 40% hearing loss. What's happening in the brain prior to being fitted with hearing devices. So I should just mention that we're going to be talking quite a bit about the treatment of hearing loss. And for the most common forms of hearing loss, there are permanent kind of a hearing loss. The most effective treatment at this point in time is in fact hearing aids, or we like to call them hearing devices. This session is not about ramming hearing aids down your throat or anything like that. It's to give you a clear sense of just what are the consequences of leaving this condition untreated, and what happens when we do apply the correct treatment to it. So the thing that's the most different in the brains of people that have untreated hearing loss is we see an overactivity in this frontal part of the brain here. So this frontal part of the brain here is really hard at work in people that have untreated hearing loss, because part of the role of this area is to integrate bits of information from different parts of the brain. So when we're not hearing words in full, when we're hearing parts of words, we're needing to supplement what we can hear with what we can see. Often we're needing to add in some context. So these parts of the brain are hard at work putting bits of information together from different parts of the brain. Quite hard work. Ask anyone that has a significant hearing loss what it's like for them at the end of the day after interacting with different groups of people in challenging environments, and they'll tell you that that process is quite exhausting. Some people can describe it as like going 100 kilometres an hour in second gear. We can actually start to see some thickening in people that have long-standing hearing loss. We can actually start to see some thickening in these frontal parts of the brain because they're just working so hard. This research also did find, I guess, underactivity in the hearing centres of the brain. So 14 people in the study, they all received what I like to call the holy trinity of the correct treatment for their hearing loss, which is good quality and appropriate for them hearing devices. They were fitted using best practices, which should always be used, that we know aren't always used. And most importantly, the people in this study, they wore their hearing aids for at least 12 hours a day. The thing is, particularly here in Australia, we know that most people that own hearing aids, we know they don't wear them. We know how often people are wearing their hearing aids because they've got little databases on them, teeny tiny little databases on them, and we check. And I would say that the most important part of an audiologist's job is to create the conditions whereby their patients are actually utilising the treatment. It's just super critical. There was a major study done here in Australia with 15,000 hearing aid owners or hearing device owners, and the researchers looked at the data logging with 15,000 people. And they found that a third of people that own hearing devices in the study, they really weren't wearing them. They had them in the bathroom cabinet, they are in the top drawer. They found people are actually wearing them in their pockets. And if they were wearing them, it was for less than 2 hours a day. Another third of hearing device owners are what I'd call my reading glass wearers. So they might pop the devices on to come to a session like this, maybe to go to a family function or something like that. But most of the time they're not actually wearing their devices. Between 2 to 12 hours a day. Only a third of people that own hearing devices here in Australia actually wear them as they should, which is at least 12 hours a day. So if you've got hearing devices, if someday you need them or you know someone that has them or needs them, the best advice that any audiologist can possibly give you is that those devices really need to be in for at least 12 hours a day. The best evidence that there are brain health benefits from treating hearing loss comes from studies where people consistently utilize the treatment. And Jeffrey and I can tell you from a practical point of view, working with treating hearing loss on a full-time basis, that the difference between our patients that are in the habit of keeping their devices in for at least 12 hours a day versus those that we might describe as our reading glass wearers that pop them in once in a while, it really is like chalk and cheese. So these people, they've got the holy trinity of the correct treatment for the hearing loss. I should say I'm a little bit nervous sometimes when I'm talking about the holy trinity of the correct treatment of hearing loss. I was invited a few weeks ago to present at the University of the Third Age, or we call it U3A, and they didn't have a kind of a setting like this for the meeting. They actually meet in a church, and so they had me up there at the altar, presenting to the congregation about the Holy Trinity of the correct treatment of hearing loss. But a bit less nervous in this room. So what happened is that they came back into the lab 12 months later and had their brains scanned again. And what the researchers found was that the hearing centers in the brain in these people had grown back in a way that was determined to be statistically significant, which is to say that these parts of the brain literally grew back in a way that wasn't just by chance. This was as a direct result of having the correct treatment for the hearing loss. Probably my favourite study in the field of hearing and brain health was done at the University of St. Louis. Actually, parts of it were replicated here at the University of Melbourne. And what the researchers found was evidence of what we call cross-modal reorganisation occurring in the brain. So cross-modal, what does that mean? Basically, they found evidence of the visual centres in the brain starting to encroach on the hearing centres in the brain. And how they were able to demonstrate that was by flashing visual stimulation into the eyes of these people. There were 26 people in the study. So that visual stimulation was actually showing up in the hearing centres in the brain. It really shouldn't be there. And it's a sign that as a result, and I should mention, by the way, these people, they had a mild hearing loss. So the people in the study, they had around a 25% hearing loss, the kind we never used to care about. So it was showing up here. They also found that the participants performed significantly worse for tests for hearing in background noise in groups compared to those that had normal hearing. And they performed significantly worse on a range of cognitive tests. So when I'm talking about cognitive abilities, I'm talking about things like short-term memory, processing speed, our reaction times, what we call our general executive functions, all of which are capacities that we need to live day-to-day life independently. All of these become impaired when we've got a hearing loss that we've done nothing about. They also tested, they saw the visual centers kind of taken over the hearing centers in the brain and thought, well, maybe that's going to help these people become better at lip reading. However, they also found that the people with the hearing loss, whose brains look like this, perform no better at lip reading tasks than people with normal hearing. So it's not really a beneficial adaptation that's occurring in the brain here. So again, these people, they receive the holy trinity of the correct treatment of the hearing loss. Good quality, appropriate for them hearing devices, fitted using best practices, which should always be used. And they weren't as strict in this study. They kept their devices in for at least 10 hours a day. So 6 months later, they came back into the lab, had their brains scanned again. And what the researchers found was that visual stimulation, it got out of the hearing centers and was just back into the visual, only in the visual centers where it really should be, which is good evidence that as a result of having that hearing loss treated, that that their brains are reorganized, so particularly out of the hearing centers back to the visual centers, reorganized back in, I guess, a healthy way. They perform significantly better for tests for hearing in background noise in groups, and they, like relative to how they scored at the start, and their cognitive scores also improve, so they perform significantly better on a range of cognitive tests. So Jeffrey, Nicole and I were fortunate enough to go over to the United States. It was actually literally this time last year for an intensive conference in this field. And the researcher for that study, Dr. Hannah Glick, talked us through in detail about the research her team did, and also about a subsequent study that they conducted where they thought, well, we're getting these rather dramatic results in the lab. What happens if we go out in the community, find 100 people that just so happen to be wearing hearing devices, let's bring them into the lab and run them through all the tests, scan their brains, and let's see what we find. What they found was that 40% of those people out there in the community wearing hearing devices, they were getting these effects. So they improvements in background noise in groups, solid cognitive function, visual centers in the brain doing their job directly. But they found that for 60% of people, their brains look much like this, as if they'd never worn a hearing device in their whole life. And what they found was that the majority of these people, they were underfit, meaning that so when we fit hearing devices properly, there's a process that we call real ear insertion gain, which is a little bit fiddly, a bit time consuming. Some people think of it as a bit of a nuisance. Jeffrey and I see it as being just an absolutely critical part of our work, because it gives based on the test results, we get prescriptions for the hearing loss, and those prescriptions are designed to maximize speech understanding. And unless you're following an objective process where you're measuring that the output of the devices is matching that prescription, you're going to underfit usually your patients. So what often happens in our field is that hearing aids are set up on factory estimates, and they're almost always nowhere near as much volume as people need. And so they found that most of these people that were underfit, and they also found that they weren't wearing their hearing devices for sufficiently long periods to get these beneficial impacts in the brain. So I've become a bit curious. I ask any of my patients, I'm probably annoy some of them a bit, but I'm just a bit of a broken record about keeping devices in on a really consistent basis. You get so much more benefit and value. I see it as being the most important part of my job, is to make sure my patients are utilising the treatment. I'd estimate that it would take up about 50% of my clinical time, and Jeff is the same, because it's just so important. So I looked at kind of worldwide data. I actually worked in the United States up until about 6 years ago before starting my practices here. And on average in the United States, people that own hearing devices, they wear them for 10.8 hours a day, and a couple of large-scale studies have shown that. In Australia, that figure is more like 6.7 hours per day on average, so significantly less. Key difference between audiology in the United States compared to audiology here is that the majority of the clinics in the USA are independent clinics. So they're kind of run and owned by a person like me, an audiologist, and an independent practice is able to access solutions from really any manufacturer. However, and also I found that independent practices are more likely to engage in the best practices that we need to get these kind of dramatic outcomes. In Australia, Australia has like the most corporatized expression of audiology that we really see anywhere in the world. Most of the clinics that are out there are chains of clinics, most of which are owned by overseas-based hearing aid manufacturers. Our primary concern about these clinics is that when you go to these clinics, you can have any hearing aid that you like, as long as it's the specific type that they make. What's also become I guess more of a recent trend is that often the devices fitted by chains, and I would say around a third of hearing devices here in Australia are kind of rebranded by the chain of clinics and locked to that clinic, which just presents a range of issues down the track. So just a bit of advice I'd recommend if you're looking to improve upon your hearing situation, or you know someone that needs to. I'm not saying you got to come to our clinic or anything like that, but I just encourage you to seek out an independent audiologist. The challenge is that here in Australia, only 7% of the practices are actually independent practice. So it's just worth doing that little bit of research, make sure whoever you're seeing is independent. They're not going to give you rebranded locked devices. They're going to have a range. Because the thing is, there's not one manufacturer that has the solution for the right hearing loss for the right person every single time. And even when they do, with the rate of technological change that we're seeing, 6 months down the track, there might be another manufacturer that's got a more appropriate solution. And unless you're seeing an independent audiologist, it's unlikely they're going to have access to all of the solutions. So just a bit of advice there. So I'm going to hand back to Jeffery now, who's going to give you a quick tutorial on how the hearing system works and run through a bit of the test process. And I'll hand you over to Jeffery.
Thanks, Andrew. So how the hearing works, very fascinating topic. I could probably talk about it for hours on end, but I'll keep it to the 2 to 3 minute version. I think if I gave you the 2 to 3 hour version, you'd probably wish you had some kind of hearing loss so you wouldn't have to drone on for that long. But how do we hear? First of all, what is sound? So sound is rapid fluctuations in air pressure, which propagates through the air. So sound, it travels through the ear canal, and it hits through the ear canal, and it hits the eardrum right at the end of the canal. The eardrum, it's about 2 layers of skin thick. If anyone ever told you, don't stick anything smaller than your elbow into the ear canal, that's excellent advice. Very delicate, very sensitive. So sound causes the eardrum to vibrate, and that vibration, that mechanical energy, is transmitted along these tiny little bones over here called the ossicles. The ossicles, they're the smallest bones in the human body, each smaller than half a grain of rice. These bones amplify that mechanical energy, and it directs it into this nail-like structure over here called the cochlea. The role of the cochlea is to process all of that auditory information, and it directs it through the auditory nerve before being processed by the brain, ultimately processed in the auditory cortex. The cochlea is split up a little bit like the keys on a piano, from the high pitches all the way down to the low pitches. So in the basal turn of the cochlea, in yellow here, that's responsible for processing those high-pitched sounds, high-frequency sounds. Red, that processes the middle pitches, and blue for the low pitches. What we do see, excuse me, voice is a bit hoarse, what we do see is, particularly with age-related hearing loss, we see primarily a deficit in this yellow region, in those higher parts of the ear associated with processing high pitches. We'll talk about that in more detail later on also. And it also follows, if we've got a weakness in this yellow region here, for those high pitches, we see a corresponding weakness in the brain also. If we look at the cochlea under a powerful electron microscope, we can see these two micrographs over here. So what we're looking at is one receptor cell in the cochlea. In each cochlea, in each ear, we've got about 30,000 of these receptor cells. On the left-hand side, we can see this person had normal hearing. On the right-hand side, this person had a mild to moderate hearing loss. So it's crucial to understand that when we're talking about hearing loss, we're quite literally referring to physical damage to the ear, cellular damage. So in the normal hearing case, we can see that there are these projections coming up from the cell. They're called stereocilia. They are the organelles of the cell. They're looking very neat, a little bit like soldiers standing in a couple of rows. However, in the hearing loss case, we can see that some of these stereocilia have died. There are some remaining ones over here, but they're looking pretty bent, pretty disorganized, disheveled. There are some healthy stereocilia over here. What does this mean, this physical damage mean in terms of the person's ability to hear clearly? Firstly, it means that sounds need to be louder in order for a person to detect the sound has taken place. But this physical damage also creates the perception of distortion. The quality of hearing is reduced when there is hearing loss. And that means that typically in complex settings, especially in background noise and group conversations, that person is likely to struggle because the quality of hearing is reduced. Why do we like to focus on the brain? Well, in this presentation, in the books that you've got, and also in clinic, is because the brain is said to have neuroplasticity. In a nutshell, meaning that the brain is able to change. And the amount of research in neuroscience in the past several decades is astounding. And it was probably assumed just several decades ago that our brains are fixed. Our brains, we more or less get what we're given. Our brains grow into our skulls and they remain static over time. But what we do know now is that it's absolutely not true. Our brains are constantly changing. They're on the border, they're changing right now. There are three key ways in which our brains have neural plasticity. So the first way is the ability of the brain to form new connections. And we can do this at any age. There was a woman aged 113. She teamed up with a group of neuroscientists, and they found even at that ripe old age of 113, she was able to form new connections in the brain via learning. So after today's seminar, even if you've learned one new thing, you would have successfully formed a new connection in your brain. The second way in which we have neuroplasticity is the ability for the brain to strengthen existing connections. Whenever we're practicing a new skill or learning something until we're fluent, what we're doing is we're strengthening existing connections. And the third way in which we have neuroplasticity is through a process called pruning, where underutilized connections in the brain are stripped back and repurposed to other areas of the brain that do actually get used. Much like as you may prune the branches of a tree. And depending on the part of the brain, that will determine the rate in which that pruning occurs. When we're talking specifically about the auditory system, it's about a period of 10 to 12 years of understimulation in which we start to see a permanent deficit and pruning away of existing connections in the central auditory nervous system. What does that mean in terms of our ability to hear clearly? And it poses several challenges with untreated hearing loss left for a decade or even more than that. And it really does show up in clinic too when we test these people. There are several tests. We play some words and people repeat back what they're able to hear to assess how well the hearing brain is working. But when there's a chronic deficit and deprivation of auditory input to the hearing brain, those hearing centers, they weaken. They become less effective, less efficient in processing sound. And it also can create a bit of distortion, like the radio at an off station when there is that pruning effect. So there is a window of opportunity in which we're able to see optimal results in the clinic. So the brain is plastic, the brain is able to change. We do know that with untreated hearing loss, those hearing centers can become disorganized. The reverse is also true. By treating hearing loss, those hearing centers become more efficient and more effective in processing auditory information. The ear is not plastic. The ear, well, the hearing loss we have, well, peripheral auditory system, the ear, that is a permanent, irreversible hearing loss. So why don't we open it up to the audience a little bit? Should be working. How's that? There we go. Yes. Would anyone like to have a guess? The number one cause of hearing loss? Show of hands.
Loud noise.
Someone said loud noise. That's number two. Noise-induced hearing loss, very, very common with loud music, machinery and power tools and so on. That can certainly contribute to hearing loss. That's number two.
Age.
Age. Someone here is right on the money. Aging. The medical term is presbycusis, age-related hearing loss. So it will happen to virtually all of us, assuming that we do live long enough. As we get older, there's more wear and tear on the ear. So aging, the number one cause of hearing loss.
Genetics too, no?
Genetics, so that's number three. Genetics is also related to, with age-related hearing loss, genetics forms part of that too, where some people, just based on their genetics from their parents, are just more susceptible to gradual deterioration of the receptor cells in their ear. So there is some genetic variation influencing the rate of hearing loss as we age. And show of hands, who's tested their hearing before? Most people in the audience are good. So you may already be familiar with the audiogram, which is the graph of our hearing ability. It represents the softer sounds that we're able to hear across a range of pitches. So how to read this graph? Right at the top of the graph, we've got complete normal hearing right at the top. And as we move further down on the graph, the worse the hearing is. So at the bottom, very poor hearing. On the left-hand side of the graph, we've got the low pitches. And on the right-hand side, we've got the high pitches. So the circles and crosses, that represents our hearing thresholds. So circles for the right ear, crosses for the left ear. So what we see over here is a very common configuration of hearing loss we see all the time in clinic, particularly with age-related hearing loss, where the hearing is in worse shape in those high pitches. What does that mean in terms of a person's ability to hear clearly? Well, without hearing loss, the person's able to hear the vowels, okay? The vowels are voiced. They've got a sense of volume and power behind them. And of course, we've got the consonants also in English. Consonants, they're typically softer than vowels. With this hearing loss, the person's able to hear the vowels okay. The vowels indicated by that dark blue oval. But however, it's the consonants represented by that black oval there. This person's able to hear parts of the consonants and they're missing out on other parts. And that's due to their hearing loss. They can only hear parts of what's being said. And this makes things difficult and challenging. This type of hearing loss places additional cognitive load on the person, where the person's brain is needing to work extra hard to process an incomplete auditory input. And it's much easier to hear things clearly in whole, rather than just hearing parts of what's being said. Just a bit of an exercise to demonstrate the importance that consonants have in understanding speech clearly. Just a bit of I think, an entertaining exercise. So let's just imagine this is a text message from one person to another, where we've only got the consonants here. I'll give you a few minutes. See if you can decipher what's being said. So over here, we've only got the benefit of the consonants. And now we'll try it with an age-related loss. Over here, we've only got the vowels. Probably not as easy, if you ask me. So now, of course, with the consonants and the vowels in entirety, we've got, dear Karen, how's everything? Will you meet me for lunch tomorrow at McDonald's? Love, Howard. So obviously much easier to comprehend what's being said when you get the full message. A bit of a fun exercise, a bit of a simplification too, because even with age-related hearing loss, we do still hear some of the consonants, but just demonstrates the importance of consonants in understanding speech clearly. And with age-related hearing loss especially, it's the consonants that are predominantly affected. And now I'll hand back over to Andrew. Thank you, Jeffrey.
So I should mention that Nicole's come around and passed out a few forms to you. It's just really helpful for us to, it's a feedback form that lets us know that they've arrived, and it just helps us understand our audiences a little bit better, so we can craft the content in hopefully a way that's beneficial and relevant to you. Usually comes up with questions at the end, but the issue of tinnitus, so tinnitus like ringing in the ears, is that something that anyone here is impacted by at all? So yeah, so a good number of you. I'll make a point to leave some time for questions to address it, at least in part. It's potentially a whole other seminar topic on its own. So So I won't be able to cover the topic in full. But what we've done is we've put together quite a comprehensive guide on tinnitus, um, and it's we call it our complementary tinnitus resources. Part of the treatment for tinnitus is, in fact, learning a lot of the facts about it. There's a lot of rubbish about tinnitus on the internet that's not particularly helpful. But learning the facts about it, because the better you can understand, I guess, the true nature of the condition, the better you're able to actually deal with it. So if that's of interest to you, on the form there, around the middle of it, there's a please send tinnitus resources, just a little tick box. You just tick that one and make sure we've got your email address on top, and we'll email you out the complimentary tinnitus resources. There's quite a bit to it. If you hadn't guessed, we actually quite enjoy giving these presentations. So if you are part of a community group that invites guest speakers the kind of group that may be interested in this topic, just make a note there on community presentations, and we can come back and try to make some arrangements if you're part of a group like Probus, U3A, independent retirement communities that they tend to appreciate this kind of content. Just make a note and we'll come back and confirm that. And also one thing that we do offer anyone that's taken the time out of their day to come and join us for an in-person seminar is a complimentary consultation at our Hawthorne East practice. If that's of interest to you, just tick yes down at the bottom of the form, and make sure we've got your contact details there, and we'll come back and confirm a time. We do like to do a quick introductory phone or video call ahead of our in-person appointments, just to give you a better understanding as to what to expect and how to find us and things like that. Yeah, we're happy to offer that to you, and we'll grab those forms after the session. But in terms of, so Jeffrey spoke quite a bit about the sense of hearing and how that works and how we measure it and so on. I find, just to give it just a little bit more insight as to how our brain becomes involved in the process, is to give the example of someone whose hearing is uneven. So they've either lost hearing in one ear, potentially completely in one ear, or they're doing what we used to do up until about the 1980s, and fit someone just with one hearing aid. And so in any case, the hearing's out of balance. That person's hearing better out of one ear versus the other. But one thing that is going to be a challenge for that person is to hear where sounds are coming from. So how we hear where sounds are coming from is by subconsciously comparing the difference between the ears. If the hearing's right out of balance and I've got a sound that's over here, it's going to hit this ear slightly quicker than the further ear due to the speed of sound, and it's going to be slightly louder in this ear relative to the other ear. When my hearing is in balance, there's quite a bit of teamwork that occurs between the ears to work out where that sound's coming from without us really even thinking about it consciously. However, when the hearing's out of balance, that becomes really difficult, which is not just a safety concern, when we want to go across the road and so on, but can present a practical nuisance, particularly in social environments. If, say, a cocktail party, someone starts talking to you, it takes you that split second longer to see their face so you can help put the bits together. Chances are you're going to ask them to repeat what's being said. Probably the biggest complaint that we get from our patients whose hearing is out of balance is difficulty hearing in background noise and group situations. So there's quite a lot of teamwork that happens between the ears that help us hear better in background noise and groups. Around 80% of what we hear goes to the opposite side of the brain, and there's quite elaborate feedback to that opposite side and back to the original side. One of the really important processes is allows, particularly when our hearing's intact, to really focus on what we want to hear, particularly that person in front of us, and suppress outside other sounds. That all gets out of whack when we've got an imbalance in the hearing. Also, too, one of the big reasons why in this day and age, when there's hearing loss in both ears, we'll always highly recommend a pair of devices, is because what they found in around the 1980s, right, 1970s, is that for people that got fitted with a single device, they experienced what we call auditory deprivation in the unaided ear, and basically due to a lack of stimulation, the hearing centers in the unaided side started to become less effective. So if 5-10 years down the track we decided to fit a hearing device on that side, we didn't have a whole lot of luck. We start to get, when we've got, I guess, chronically understimulated parts of the hearing system, we can start to get some distortion coming into the system. Certainly in this day and age, we always recommend a pair of devices to balance the hearing up, and to keep the associated pathways stimulated and working really well. Also, too, what we found is, particularly in the past 4 to 5 years, the makers of hearing devices, they're better understanding the processes that occur between the ears, and that's starting to inform the how well the hearing devices work, particularly their capacity to work well in background noise and groups. For me personally, I always look for a feature called binaural beamforming in hearing aids. Binaural meaning both ears, beamforming their ability to work together as a team in background noise and groups. It's just one of the few features in hearing devices that where there's some really good scientific backing that it does what it should, particularly in background noise and groups. I've written a bit about that in my book there. We do see some people that have completely lost hearing on one side, either through kind of childhood illness, or some people get just a complete sudden loss of hearing in one ear. So what we're able to do with those people is work with a solution called a CROS solution, where we have a device on the ear where there's completely no hearing, and a device on the good ear, and that device on what we could say the dead ear is it picks up the sound on that side and routes it over to the good ear, and gives that person the perception that they're hearing equally in both ears, so they're able to hear where sounds are coming from, hear better in background noise and groups, and hear people on that side that they otherwise would have no hearing. So we're getting to the point where technology is really starting to support what we do for, I guess, a wider range of people.
And I'd like to share with you all just a personal story about my father and his experience with hearing loss. He's got a considerable hearing loss. That's much worse than the average person of his age. When I was living with him at the time, he would constantly remind me just how much of an impact that it had on his life and his ability to function and to probably enjoy his life. It isolated him, his hearing loss. And not only that, it posed a significant barrier to his career aspirations, and he had to give up on those aspirations because it was too difficult to communicate effectively. He was always pretty quiet, pretty introverted by nature, but everyone, no matter their personality type, needs to have quality human connections. And the reality is that his hearing loss isolated him from people. When I was living with him at the time, he was constantly asking for repeats, and I was constantly having to repeat myself. My sister as well, constantly, she was repeating herself. My mother, however, well, she had a very loud and forceful voice and personality, so at least he had no trouble hearing her. And it was a decade ago, if my dad stepped foot into an audiologist's office, much to my surprise, because there was so much pressure from us, his family, to convince him to treat his hearing loss. It was annoying having to repeat ourselves all the time, but for him, there was very little intrinsic motivation to do anything. Firstly, he was quite vain, bald at the time, no hair to cover up a potential hearing aid behind his ear. I think also hearing aids conflicted with his self-concept of who he was as a person. He felt like hearing aids was an admission to the fact that he was getting older. I mean, of course he was getting older, but hearing aids made him feel older than he felt with his self-concept. And so he demoed a pair of hearing aids for a couple of days, day or two, before he tossed them aside and decided, no, not for me. After just a couple of days, I was exasperated. What we didn't realize is it takes time for the brain to physically readjust, to adapt to the hearing aids. Usually a couple of visits to the audiologist to fine-tune the settings, but he didn't realize any of that, and he gave up on hearing aids prematurely. And when I first got into audiology, I had countless conversations with him in vain, trying to convince him to treat his hearing loss. By then, I wasn't only concerned about his relationships with people, his ability to communicate with others, but I was also concerned about his brain health. I was reminded of my late grandfather. In his later years, he was diagnosed with Alzheimer's disease, and that turned him into a completely different person, and I didn't want that kind of fate for my dad. And it wasn't until one day we had a candid conversation around the dinner table, and he mentioned to me that he wasn't able to hear the very loud kitchen oven timer. And that was the moment. He was personally convinced that his hearing loss was unacceptable and he needed to do something about it. And so I put him with a pair of hearing aids, with them in to hear so much better, much, much better. And it just got me thinking also, in the grand scheme of things, life isn't all that long. If we're lucky, we'll live into our 90s, maybe even older than that. But why live with a needless handicap that isolates you from people and stops you from connecting to the rest of the world? Why not live to the fullest that you can? And hearing, as we'll discuss later on, is a critical part of that. I'll throw back over to Andrew. Thank you, Jeffrey.
So I'm just going to talk just a little bit about dementia now and just how that relates, I guess, a bit more specifically to our sense of hearing. So dementia is not a specific disease on its own. It's essentially a descriptive term for a cluster of symptoms. And the most common form of dementia being Alzheimer's disease. There's other forms of dementia. We won't be going into all the different types. But in terms of overall symptoms, one of the ways in which someone may be diagnosed as having a dementia or not is by the significant presence of at least two of the following issues up on the screen. And these are listed in order of importance or significance. It's not all that clear, but right up the very top, as you might predict, is in fact memory loss. So we've known for decades that the more effort people need to put into following conversation, particularly in a background noise or a group situation, the less of that conversation that they're actually going to remember. When we look at the memory centers in the brain and people that have significant hearing loss, we can see physical impact. particularly in the hippocampus, which is a rather critical part of the memory centers of the brain. But if we think about particularly the cognitive impact, so probably our most important cognitive ability is our short-term memory. So for most people, short-term memory, we can hold up to 7 bits of information in our short-term memory at any one time. You might recall when home phone numbers were 7 digits long, they were far more easy to remember than, say, a mobile phone number. 7 bits of information is not a whole lot. So particularly if we're trying to follow conversation in the presence of background noise or groups. So we're trying to, I guess, extract out the bits that we're wanting to hear, coin that with the visual cues, body language, facial expressions, movement on lips. So coin that with the bits that we can hear. Often that's not enough. We need to add in some context and combine that with the bits that we can hear, with the bits that we can see. And this is with a flowing conversation. So it doesn't take a whole lot for our short-term memory to really start to saturate. And what we know about short-term memory is that the more saturated and overloaded it becomes, the less resource there is for encoding into long-term memory. So clear links between hearing loss and memory loss. I'll mention a little bit later, a very recent study came out about 3 weeks ago that looks specifically at the memory centers of the brain and with different levels of hearing loss. So communication difficulties next on the list. So hearing loss being the most common communication difficulty that we have. Part of the concern with communication difficulties is that they result in a significantly increased risk of social isolation. I like to compare and contrast hearing loss with vision loss. There are 2 primary senses, yet we know that, at least here in Australia, people are 5 times more likely to address a vision loss than they are a hearing loss. The thing is with a vision loss, though, is when you have that, particularly a partial vision loss, it's kind of like your problem. And when you go and get a new set of glasses or perhaps have cataract surgery, things are just that bit better for you. Able to read the paper, potentially driving, and so on. There's a range of conveniences that are good for you, but don't necessarily have a direct bearing on the quality of life or well-being than really anyone but yourself. When the things with hearing loss is that usually it's other people that notice the hearing loss first. Usually it's other people, particularly close family members and spouses, that are more concerned about the hearing loss than the person that actually has it. At the University of Queensland, where I did my master's degree, about a year after I graduated, there was a study done on 100 couples and to be part of this research, one person in the relationship needed to have a significant hearing loss and the other completely normal hearing. So they took the people with completely normal hearing and put them in a separate room, did a range of tests. And what they found was that those people with completely normal hearing were actually diagnosed as having what we call a third-party disability. 84% had a third-party disability as a result of their partner's hearing loss. And for 18% of these people, it was really clinically significant. They were diagnosed as having a third-party disability for communication. Nothing was wrong with their hearing. It was as a result of their partner's hearing loss. So what we see with hearing loss is that because of the impact on communication, the impacts of that hearing loss tend to be far-reaching beyond the individual person that has it. So it's rather unique as a health profession in that frequently the impacts on other people are more significant than the person that actually has that health condition. As we go down the list, we come to attention deficits. So attention deficits in this context relate to a whole host of our cognitive abilities that relate to our ability to sustain attention, to divide attention, to focus attention. We know that these abilities become impaired when we've got a hearing loss that we've done nothing about. And it can start to take away from other faculties, including balance and steadiness. So a number of studies have shown this. One was done with 20,000 men that had been admitted to hospital for one reason or another. So they had the reason why these guys were admitted to hospital on record, and they also had the hearing test results of these guys. And what they found was that that men with that at age 60 that had a mild hearing loss, so about a 25% hearing loss, they were 3 times more likely to have been admitted to hospital because of the fall relative to their peers that had normal hearing. And for every 10% of additional hearing loss, their falls risk doubled. So we know that that falls are the leading cause of accidental death for people that are over 60, and there is good evidence that that treating that hearing loss consistently worn hearing devices can in fact help mitigate that increased falls risk. The next 2 issues on the screen here, so regionally judgment issues, visual perception challenges, not so related to our ability to hear well. But if we think about it, I guess the top 3 most significant criteria for dementia diagnosis have some bearing on our ability to hear well. So dementia prevention has become a really quite a hot topic. Currently, dementia is the leading cause of death for women in Australia and the second leading cause of death for men, followed by coronary heart disease. Over the past 10 years, dementia-related death has increased in Australia by 68%, yet death by coronary heart disease has actually decreased by 19% over the same period. So the medical community have become better at treating different parts of the body. However, when it comes to brain health, so either preventing cognitive decline or we don't really have treatment. We don't really, in reality, at this point in time, when it comes to cognitive decline, what we really have is prevention. So the Lancet Journal, which is the most prestigious medical journal on the planet, they've done 2 major reviews looking at, well, what does the world's best research tell us about dementia prevention? And basically they've come to the conclusion that based on the world's best research on the topic, would indicate that up to 40% of cases of dementia could be prevented through long-term lifestyle modification. They've come up with I guess, the top 12 factors, what we call modifiable risk factors, things that we can do to help reduce our dementia risk. And they've kind of ranked all of them in order of significance. So if we look at the second on the list here, second on the list is less education. As adults, the remedy for that can be a habit of lifelong learning. So of all the 101 things that you could be doing this evening, you've made the decision to come to a session like this where hopefully you're learning a thing or 2. And I just urge you to do what you can to establish a habit of lifelong learning, because it really is one of the best things that you can do for your brain health. Right up on the top of the list is in fact hearing loss. So the Lancet Journal defined hearing loss as the #1 modifiable risk factor for the prevention of dementia. Modifiable meaning that there's actually something that you can do about it. Why is it on the top of the list? Well, we know that hearing loss is really common, as Jeffery indicated. Pretty much everyone that lives long enough will experience it. We know that impacts on brain health can be devastating. But we also know with hearing loss that treatment is actually really effective, particularly when it's the right treatment, when it's fitted correctly, and it's worn on a really consistent basis. As we go down the list, there's hearing loss, less education, smoking's there. I'm not sure how many smokers we have, but the next 2 are interesting in that they are depression and social isolation. And we've known this for decades that with increasing levels of hearing loss, we also increase that risk of depression and social isolation. So if we look at the put this all together and look at, well, what does the world's best research tell us about dementia prevention? Those factors that are either directly related to hearing loss or indirectly related to it. More than half of the things that we can do to help reduce our risk of developing these diseases of the brain relate in some way to our ability to hear well. And if we're serious about about a habit of lifelong learning, it's going to be beneficial for us to be able to hear well if we're attending seminars, webinars, learning, communicating in groups. It's really important. So I mentioned Professor Frank Lind earlier in the presentation. His team was behind that I guess foundational research that identified increasing levels of dementia risk with increasing levels of hearing loss. Well, his team, he was able to source $40 million worth of funding for around 7 years ago for a major project that looked at, well, the impacts of untreated hearing loss are relatively well understood. What happens when they apply the correct treatment for that hearing loss under really quite well-controlled conditions? So they did a major study using, I guess, a gold standard of research techniques, randomized controlled trials, and basically had 1,000 people in this study, half of which got hearing aids, half that didn't, and they studied them over a 3-year period. And what they found was that for people in the study that were at risk of cognitive decline, it actually cut the progression of their cognitive decline in half relative to those who didn't wear hearing aids. So, in summary, in older adults at increased risk of cognitive decline, hearing intervention, hearing devices, slowed down loss of thinking and memory abilities by 48% over a 3-year period. And they actually found that as a group, there was no significant degradation in memory abilities in the people that wore hearing aids. However, there was degradation in memory in those that didn't. Another 3-year study that was done over, I guess, a similar period was actually done here in Melbourne. And what they were looking at, 160 people in this study, they were looking at the impacts on cognitive function in the group of people in the study that wore hearing aids versus those that didn't. And what was interesting in this study is that it was done over 3 years, but they took a reading halfway through at the 18-month point. And what they found was that the people that wore hearing aids in the study, their cognitive function improved over the 5 dimensions of cognitive function that were investigated in the study. It improved relative to those that didn't wear hearing aids over that same period. Then the notorious Melbourne lockdowns happened, and what they found was that the people in the study, they stopped wearing their hearing aids as much as they were previously, and because of the lockdowns, they were also not interacting socially because locked up at home. So at the 3-year point, after 18 months of lockdown, they found that the people that wore hearing aids, they had maintained their improved cognitive ability over 4 dimensions, but they dropped off on a 5th, and that was general executive functions, which is a cognitive ability that helps integrate and combine other cognitive functions. That dropped off. So what that tells me, it was one study, and relatively small, was that because they stopped using their hearing aids on average for, I think it was around 3 hours a day less as a group relative to pre-COVID lockdowns. So it tells me that further support, that consistent use of hearing devices is really important, as is ongoing social interaction is really important for our cognitive abilities. I mentioned impact on that hearing loss has on the memory centers in the brain. And about 3 weeks ago now, a study came out and it looked at a group of people that were age 70, all born within in the same week. And they looked at their cognitive function and their MRI imaging of the memory centers in the brain, particularly the hippocampus. And what they found was a direct correlation between the participants' hearing level and the state of the hippocampus. And they could actually predict the degree of degradation in the memory centers in the brain as a function of the hearing levels of these guys. So clear links between hearing loss and memory loss. So kind of really in a nutshell, if we, we're putting all these things together, we've got cerebral atrophy, so the physical impact of that hearing loss that's putting on the brain, shrinkage effects, and also some disorganization effects in the hearing center of the brain, that consistent cognitive load that having a hearing loss puts on those cognitive abilities, and also the impacts of social isolation. But I've just got a really quick question for you, and there's not, this isn't like a right or wrong, pass or fail kind of question. And it's not a trick question either. I know we're at a kind of a hearing seminar, but I'd like you to consider, if you were given the choice as to be completely blind or completely deaf. So the decision that you need to make is whether to lose your vision completely or to lose your hearing completely. So faced with that choice, who here would choose to keep their vision? Just about everyone. Who here would choose to keep their hearing? Wow. Okay. I think we're dealing with a bit of an enlightened group here, Nicole. So, okay. So who chose to keep their hearing? Yeah. Okay. Great. Lady in the middle there. Oh yeah. Yeah. Now, was there something specific about your hearing that you'd want that made you make that decision?
Yes, I'm losing my hearing, and I love parties and socialising, and it's impacting my life. And I think I have a cousin who's blind.
Yeah.
And he can still enjoy all of that.
Sure. Yeah. Okay, there you go. So is that impact particularly on communication in those challenging settings? Yeah, yeah. So for people that are listening online, so by the way, we've got almost as many people on Zoom here that are joined us kind of remotely. So the lady was saying that she's finding that she's starting to lose her hearing. It's having an impact on the particularly parties, social situations, hearing there, and relative to a friend who is vision impaired, who doesn't seem to be as impacted. Great. Now, can I put you on the spot, just right in the corner? So, is there something about your hearing that made you kind of make that choice?
Because similar to what you were saying,
Yeah.
and still have a lifestyle before you came, and because there's such a lot of pain out there. Because if you've lost your hearing, you cannot really interact as well.
Okay, so
you tend to isolate.
sure. So with a hearing loss, it's particularly with communication can be isolating because you're not interacting as much with others. Well, this would have to be the most enlightened group that I've spoken to all people. So when we ask that same question in formal research settings, 83% of people choose their vision, 17% choose their hearing, and by the way, around 83% of people with a vision loss do something about it. A generous estimate of people with a hearing loss that do something about it and actually consistently wear their hearing devices, it's around 17%. I think it's a bit lower, but when people are put on the spot and directly asked, well, what is it about hearing that made you make that choice? Usually, the topic of communication never comes up. People say, oh, music, I couldn't live without music, and I'm not saying there's anything wrong with that. They also say, oh, the sounds of nature, couldn't live without that. Some people say, oh, I like to hear babies crying. Now, how hearing babies crying is like your favorite sound in the whole world. I've got absolutely no idea. It comes up. Very rarely does communication ever come up. I did a presentation here in Melbourne. There's about 100 people, and the only two people this is last year, the only two people at this session that put their hand up for hearing were a husband and wife. And I did what I normally do and put them on the spot. And I said, well, what made you make that choice? And they said, oh, we're both ophthalmologists, we're vision surgeons, and we see people that lose their vision. It's just part of the territory, people become completely blind, and often there's comorbidities. So whatever it is that made them blind, can potentially make them deaf as well. Sometimes they get their vision back, and so on. And what they've observed is that the impact of hearing loss is far greater on quality of life than people that lose their vision. And they indicated, and know there's studies out there that indicate that people that lose their vision completely a year later, I mean, obviously there's lifestyle adjustments and things, but overall happiness is much the same as it was prior. But that impact on communication, rarely does it ever come up. And I guess in my experience of doing this kind of work is, given that we know people, there's a subset of people that avoid treating their hearing loss like the plague. It takes around 10 years to actually go and do something about it. I just tend to think what I've experienced is that communication tends to be something that we take for granted until it's at the point where it's really having an impact on lifestyle and relationships. Then we get to the point where we really do start to value it. I think there's this. I think it's just my personal opinion is that we've got a bit of a cultural blind spot there, and hopefully with more education about the topic, people start to see it just a little bit differently. I'll just mention one study that has been going for a bit over 85 years now. It's known as the Harvard Happiness Study. Basically, it started out as a bit over 85 years ago about, well, what is it that makes a happy life? And so the researchers thought, well, let's track a group of people over their whole entire lifespan, study them intensely, and try to answer that question. Well, what is it that makes a happy life? Is it
a happy wife?
Is it a happy wife? Is it the kind of job that you have? Is it kind of where you grew up, or how much money you have, and so on? And it's kind of morphed into a study of well-being. So of people that have the highest levels of well-being, what is it about them relative to other people that gives them that? And the short story is that basically what they've found is that people with the lowest levels of well-being are the socially isolated and lonely. Life expectancy is lower, physically smaller brains, and significantly more likely to become depressed. Whereas those that had the best quality close relationships, they hands down they scored the highest, they consistently scored the highest in well-being. So the quality of those close relationships. So in a nutshell, if you could help me out here, what's kind of something that needs to be there for a relationship to be of high quality? Okay. Beautiful. So yeah, and hearing can certainly assist with that. And it's just one of the things that degrades primarily as the hearing goes down. So I think we could all agree that quality communication is just fundamental when thinking about quality relationships. I'll just mention really quickly, in our practice, we're a little bit fanatical about fanatical in the nicest possible way about keeping hearing devices in on a really consistent basis. So we've developed a bit of a program to help our patients be successful with treating their hearing loss. We call that out of the box. The core message being if we're going to be successful, those devices need to be out of the box, out of the top pocket, out of the drawer, and actually on the ears, consistently being worn. So we've got workbooks that we give our patients when they get fitted, and we occasionally do workshops for our patients as well. We support a program called All Ears Cambodia. They're a hearing charity in Phnom Penh, Cambodia. I've got over there to help train their audiologists. So the first time was in 2012. They had 4 audiologists then, they've now got 11 of them. Another way in which we support them is by sending pre-loved, because we know for a fact that there's thousands of hearing aids in top drawers, bathroom cabinets, just laying around the home. Here in Australia, some they might have been replaced, but if you know of anyone that has, or if you've got old hearing aids around the home, if you can send them into our clinic at Hawthorne East, and we'll fix them up and we'll send them over to Cambodia where they will actually get utilised. But I'd like to just leave you with a final take-home message. And that is, I'd like you to think about hearing loss just like you would any other chronic illness. So coronary heart disease, diabetes, cancer, there's no blanket cure for these chronic illnesses, but there are effective treatments. And as your doctor will tell you, those treatments are most effective when they're applied early. We know that hearing loss is a progressive degenerative disorder with neurologic involvement, and we get our best results when we catch it early and we treat it early. So thank you so much for your time and attention this evening.
So that work doing in Cambodia is fantastic.
Yeah, thank you.
It's really good.
Yeah.
Yes.
Yeah, now they're completely dependent on our on outside support. We had a couple of questions from people online. One of them was, okay, well, and this is probably the biggest pushback that I get about wearing hearing devices like at least 12 hours a day. And it goes something like this. Well, if I'm at home alone and I'm not having a conversation with anyone, well, what's the point of keeping my hearing devices in? Well, the thing is, hopefully you're still breathing, right? And you're going to be hearing a bit of that. You're going to be hearing footsteps, refrigerator running, air conditioning, potentially traffic outside, birds, wind in the trees, most of which are not really important things to be listening to all the time. But in that process, in hearing all those kind of ambient sounds that are generally always all around, your brain is becoming progressively more skilled at helping you focus on what you want to hear and filtering out those extraneous sounds that are not important to focus on all the time. So the more the devices are worn in those situations that are not particularly challenging, your brain is becoming progressively more skilled at helping you focus on what you want to hear. So then when you do go out to that cocktail party, family function, or otherwise difficult environment where there's competing noise, the more those devices have been in the simple times, the more skilled your brain is going to be at being able to help you focus on what you're wanting to hear. Another thing that happens is that the more they're in, the more consistently we're overcoming that barrier or hurdle that the hearing loss is putting into place, and we just get more strength back into the system. So those pathways strengthen because they're being consistently utilised. So the more strength we have back in the system, the better we're able to perform when we're under kind of a lot of pressure and there's a lot of background noise groups. So so there's hands down the number one, the best advice I can give is just got hearing devices, just keep them in on a really consistent basis. Were there any other anyone else have any other questions? Yeah.
To retain hearing, because I realised that I've got a number of friends who are very hard of hearing.
Yeah.
And it's such an effort to communicate with them
that you tend to isolate them without meaning to, and then I feel terribly guilty.
Yeah.
But it's such an effort.
Yeah, sure. Yeah.
And even to invite them to things because it's such a difficult.
Okay. Yeah, sure. So the point there was about how much of the, I guess in a nutshell, how much of a challenge it is for for family communication partners to, I guess, help to try to compensate for the hearing loss. So yeah.
I keep going, people should come.
Old people. Okay. Yeah, sure. Yeah. It's like hearing it just hands down. It really is a family affair. It's I think the better family members understand. I mean, we always try to encourage our patients when they're coming in for initial assessment to come along with a family member. I mean, there's a lot to take in, but also it's really helpful for family members to understand the nature of the condition. What we find is that just to be a bit general, women are pretty open to that, to come along with a family member. There's a subset of guys, of men, that like to come in on their own, and they feel that they can kind of get off the hook a bit easier. We're not sure whether they give other family members the full story when they get home, but anyway.
So are you audiologists? So
Yeah.
if somebody is detected and fixated with the
Yeah.
audiology test and
Yeah.
say, go and see an audiologist,
Yeah.
they can contact you.
Yeah, exactly. Yeah. So Jeffrey and I were both masters trained audiologists. Yep. I had
An accident recently,
Ah.
and fighting with engaged community.
right.
And I was in university the other night, there, and someone came around the corner. Let's say she went into the back, and then the first thing she said when she got out of the car, if you have a hearing aids in.
Oh.
No, I get blamed for that.
Oh, gee.
Wonderful.
No. Yeah.
Your email at Australian Hearing Services
Yeah.
may not use best practice.
Yeah.
That's who you're sent to, not like.
Yeah.
Line.
Yeah.
And it's being sent to. For
Yeah.
your service checks.
Yeah.
assessments.
Yeah.
Then you start.
Yeah. Yeah, so here in Australia, they're a government-owned company, and they used to be like when I went through university in the early days, and maybe Jeffery, they used to be kind of like the bastion of ethics in audiology, and I think they've got a special contract for children, and I think it's a little bit different with I think they've got a bit more funding and flexibility for children up until about the age, I think 26, isn't it? Yeah. But more recently, so last year, they used to work with primarily with a supplier called Signia, who's a reputable brand that is we work with them quite a lot, good quality devices. But last year they made the decision to become a white label provider, meaning that they've now got their home brand of devices, which is kind of like branded as here in Australia. And unfortunately, they're locked to here in Australia. So I've had a couple of times where someone's Jeffrey and I, we do quite a lot of fix-up work in our clinic, and so they've here in Australia, Amplifon, Specsavers, and Costco, they white label and lock their devices to the clinic. So if someone wants a second opinion or isn't happy with whoever they've seen at one of these companies, and we do a lot of fix-up work in the clinic. We're very limited in terms of what we can do because they're kind of locked to the provider, and it kind of makes it it presents a challenge or a barrier for people to to get a second opinion or have the work checked over or potentially improved. We see a bit, like I'd say there's a kind of a small percentage of people that we see that kind of tend to shop around a bit with, like, in terms of which brand of hearing aid and things like that. The most significant part of the equation, that whether someone's going to be successful or not, in our experience, is the competence of the clinician that's being seen. And if the devices are locked to the clinic, that removes, you kind of forfeit your ability to kind of, get them adjusted by someone who knows what they're doing a bit better. So again, it's just the most consistent, hopefully, message is that you're best placed to see an independent audiologist. They're not going to be, no independent audiologist works with locked devices. They've got access to all of the solutions that are out there. It's just, rarely do we do fix-up work from independent clinics. So yeah, great. All right. One more. Okay.
Microphone gadget.
Oh yeah, yeah. So in addition to hearing aids, there are some assistive technologies. Some that work with TV. Most of them work with mobile phones. There is potential for remote microphones. Tend to be like what we tend to try to do is keep things as simple as possible. And I guess for most people that we see, the hearing devices on their own tend to be, they do the trick. But when we get to a certain level of severity of hearing loss, then there are some assistive technologies, including remote microphones, where, if just say you had significant hearing loss, you're wearing hearing devices, I could have a little microphone clipped on my shirt, so my voice is getting picked up and sending direct to your hearing aid. So that's a possibility. More for the more, I guess, severe levels of hearing loss, where that can be really helpful. But they help to overcome distance and noise, which can be really challenging, particularly if we're way down, beyond about 50% hearing loss. And
Schools or what?
yeah, we use a lot in schools, particularly for kids that wear hearing aids. So yeah. Well, look, if you do have any more burning questions, you've got our card in your pack there. You can always email us. We'll be around just for a little bit, packing up and things like that. But hey, look, thanks for your time and attention this evening, and safe trip home. Yeah.